Welcome to everybody. My name is Giuseppe Boriani. I'm a professor of cardiology here at the University of Modena and Reggio Emilia. Together with Professor Cosio, Professor Saeta, and Professor Nichelli, we have the pleasure to chair this session. First of all, I think we have to thank Professor Fabbri for organizing this very exciting meeting. The two opening lectures introduced ourselves into the complex field of comorbidities. So this Congress has the role of stressing the value of interaction between different physicians. And we have to thank Professor Fabbri for organizing this meeting. Now we have a session focused on small vessels diseases, and we will move from one organ to another, and I think we will learn a lot. I have to start with the great pleasure to invite Professor Filippo Crea from Catholic University in Rome. He will talk on small vessels diseases of the heart. Please.
First, let me thank Leo for this kind invitation among so many distinguished speakers in so many different fields. And Leo, thank you also for the topic, microvascular dysfunction in cardiac diseases. If I can have slides, my life would be easier, otherwise I can carry on without slides. You know, for many years, our attention has been focused on, no, I cannot help from here. For many years, our attention has been focused on large epicardial vessels. And, Crea. Okay, thank you. And the reason is that large epicardial vessels are visible at angiography. They develop stenosis. It is easy for us to treat stenosis. All the focus has been therefore on epicardial vessels. But epicardial vessels represent 5% only of the coronary circulation. 95% is represented by microcirculation. And this 95% has been for many years totally missed. This is why some years ago with my friend Paolo Camici, we thought it was appropriate to propose a classification of coronary microvascular dysfunction, which was published in the New England. Mechanisms of microvascular dysfunction are complex. We can have structural alterations, including obstruction, vascular wall infiltration, and remodeling. We can have functional alterations, endothelial and non-endothelial dysfunction. And we can also have the extravascular mechanism of dysfunction, extramural compression, and reduced diastolic perfusion time. In this updated version of our classification, we propose 4 types of coronary microvascular dysfunction. Type 1 is microvascular dysfunction in the absence of obstructive atherosclerosis and in the absence of myocardial diseases. The prototypical example of type 1 is microvascular angina, which is characterized by angina, evidence of ischemia, but no spasm and no epicardial stenosis. And you can see this microvascular angina for many years has been considered a laboratory curiosity. In contrast, this syndrome is much more frequent than we thought before. This is a large population of patients with stable angina undergoing coronary angiography, more about 400,000 patients. And if we focus on patients with typical angina and a positive stress test, well, the prevalence of obstructive atherosclerosis is 50% only, which means that up to 50% of anginal patients are likely to have microvascular angina. The other mistake we have made for many years is to consider this as a benign syndrome. It's not true. This is a study from the States, the WISE project, a large population of women with 3 groups, controls, patients with angina and totally normal arteries, and patients with angina and just mild atherosclerosis. And you can see the outcome for a similar burden of risk factors, and you can see that patients with angina in the absence of obstructive atherosclerosis have a much worse outcome than control subjects. This is on the other side of the ocean. This is a Danish study, a large study, where patients were followed up for many years in different groups. Controls, patients with angina and totally normal coronary arteries. And you can see that the outcome of these patients is similar to that of patients with 1, 2, or 3 vessel disease, and much worse than controls. So this syndrome is frequent and with an outcome worse than we thought before. But also when we come to acute coronary syndrome, we tend to believe that patients with myocardial infarction have obstructive atherosclerosis. Well, this is true for 90% of patients, but 9-10% of patients with a myocardial infarction do not have obstructive atherosclerosis. And again, the outcome of these patients is not as good as we thought before. Not all patients with MINOCA, this is the acronym we tend to use for as myocardial infarction with no obstructive coronary atherosclerosis. Well, not all patients with MINOCA have microvascular dysfunction. This is a diagnostic algorithm we have recently proposed, but about 50% of these patients have a microvascular cause of angina, of infarction, which can be Takotsubo cardiomyopathy, it can be microembolism, or can be microvascular spasm. Now let's move to type 2 myocardial diseases, to type 2 microvascular dysfunction. This is dysfunction in patients with myocardial diseases. This typically occurs in patients with hypertrophic cardiomyopathy, and in this setting, microvascular dysfunction carries a prognostic signal. This is a study published by Paolo Camici some years ago, showing using PET, measured flow by positron emission tomography, and you can see that myocardial blood flow is a good predictor of outcome. And this microvascular dysfunction, if persistent, can lead to myocardial necrosis, which can be assessed by cardiac magnetic resonance. And again, there is a signal here because patients with evidence of late gadolinium enhancement suggesting sorry, I went to with late gadolinium enhancement suggestive of myocardial fibrosis have a worse outcome compared to patients without fibrosis. And this can be very important in risk stratification. As you know, one important issue in these patients is when to implant an ICD, an intracardiac defibrillator. Well, in the gray area, probably new guidelines will propose this type of approach to identify patients who need ICD implantation. This is another disease, less frequent, more rare than hypertrophic cardiomyopathy, which is Fabry disease. And in Fabry disease, microvascular dysfunction is present as well and can cause angina, anginal symptoms. In this case, obstruction is caused by accumulation of glycosphingolipids in endothelial cells. And this study, again using positron emission tomography, which clearly showed that in patients with Fabry disease, coronary flow reserve is markedly reduced. And then we have type 3 microvascular dysfunction, which occurs in patients with epicardial stenosis. When we see an epicardial stenosis, we tend to believe, okay, well, the problem is there. But the problem is indeed more complex. And this is a study we published many years ago. This is a human, just 11 patients, but with a very interesting disease. All these patients had a total obstruction of one coronary artery, but no history of infarction, because collateral circulation compensated for the total obstruction. You can see a nice collateral filling of the LAD from the right coronary artery. Well, in these patients, because there's only one single total obstruction, the ischemic threshold should be very, very stable. What we observed in these patients, this is an example, was that in contrast, ischemic threshold was extremely variable. These patients developed angina and they did operation at a very low heart rate, and then after a few hours, it went up to a much higher heart rate in the absence of ischemia and in the absence of angina. This marked variability of the ischemic threshold could only be explained by coronary microvascular dysfunction. At that time, this was, again, a laboratory curiosity, but we are learning now that microvascular dysfunction also in patients with epicardial stenosis can be clinically relevant. This notion is clarified by this very simple but elegant study published by a German group some years ago. These were patients with stable angina who were randomized to two interventions, either PCI, stent implantation, or exercise, simple exercise training. And you can see that the outcome was better in patients randomized to exercise than in patients randomized to stent implantation. Well, the only explanation of this observation is that exercise improved endothelial function, improved microvascular function, and this was important to improve the outcome of these patients to an extent better than that observed with PCI. In this setting, another important chapter is microvascular obstruction, which takes place in patients with ST elevation myocardial infarction. This is a complex phenomenon where different pathogenetic components lead to microvascular obstruction. This is an important syndrome. When we have a patient with ST elevation myocardial infarction, the best treatment we can offer is a primary percutaneous intervention. These patients have to rush to the hospital to have stent implantation. And then when we see the artery well open because the stent is there, we tend to be happy. But this is wrong, because what we are learning is that out of 100 patients successfully treated by PCI, 35 patients only have real myocardial perfusion, because in 65% of these patients, the blood goes through the epicardial vessel but doesn't reach the myocardium because of microvascular obstruction. And patients with microvascular obstruction, which can be assessed in different ways, have a much worse outcome than patients who have successful primary PCI but good myocardial perfusion. This has been shown consistently in several studies. The problem here then is that microvascular obstruction is frequent, is associated to a worse outcome, but this is an unmet, the treatment of microvascular obstruction in this setting is an unmet need, because we do not have proven treatment which improve the outcome by improving microvascular obstruction. Many trials have been published in the last few years. In red are trials which were totally negative, in orange trial borderline, in green promising trial, but nothing has been convincingly shown to really reduce microvascular obstruction and improve the outcome. And then we have type 4, which is iatrogenic microvascular obstruction, because unfortunately when we perform PCI, or also in patients who undergo surgery, microvascular dysfunction can be observed, and it is related to multiple mechanisms, but it is relevant. In this setting, microvascular dysfunction related to the procedure can be assessed by measuring troponin release after the procedure. And as you can see, this is not a recent meta-analysis we published some years ago, but data still there and substantially unchanged. And what we see when a patient undergoes PCI because of stable angina, we see we observed that about 30% of these patients have some troponin raised, and this meta-analysis clearly shows that when troponin is raised after PCI, iatrogenic microvascular dysfunction, the outcome is worse, including major cardiovascular events and also including mortality. So also in this setting, type 4 microvascular dysfunction can be clinically relevant. In conclusion, these are the 3 take-home messages I would like to propose to you. CMD is frequent in cardiovascular diseases, no doubt about it. The pathophysiology is complex, as microvascular dysfunction can be caused by structural, functional, and extravascular alterations. In some cases, microvascular dysfunction is simply a marker of disease, but in other cases, it's a useful prognostic marker, and in other cases, is an important therapeutic target, definitely in patients with microvascular angina. This is not microcirculation, is the savanna. Looks like microcirculation, but is the savanna. And perhaps here you can see a zebra, but if you look more carefully, you can see a lion. Well, this is the lion we have missed for many years. Thank you.
Thank you for this excellent talk on a very complex aspect of cardiovascular care. I think it is time for questions. One.
Thank you very much, Filippo. I need to ask you this clinical question, and of course you refer the microvascular pathology to angina. A question to you as a cardiologist is, what is the relationship with dyspnea? Dyspnea, breathlessness, and has been investigated as a potential clinical manifestation of microvascular pathology?
Leo, thank you. This is a key question because in patients with microvascular angina in particular, and again, these patients are frequent, much more frequent than we thought before. Before, the attitude was, okay, the lady, microvascular angina is more prevalent among women, gets angina, comes to the cath lab, no obstruction, therefore this lady doesn't have a cardiac problem. This has been the attitude for many years, and this is clearly wrong. It is worth noting that these patients frequently come with dyspnea, as you say, associated to angina, or just dyspnea. And the problem is that microvascular obstruction, microvascular dysfunction frequently gives diastolic dysfunction, increased in end diastolic pressure, and this promotes and generates dyspnea. And you know that one of the issues we discuss in cardiology is heart failure with preserved ejection fraction, which is more frequent than we thought before, and associated to an outcome which is worse than we thought before. And you know, these two stories are parallel. For many years we had angina, and we made the equation angina equal stenosis. Wrong. Angina can be there without stenosis. The same for heart failure. For many years we said, okay, heart failure is reduced ejection fraction. Wrong. Heart failure can be there also in the absence of systolic dysfunction. And I think the overlap between heart failure with preserved ejection fraction and microvascular angina, again, is larger than we thought before. This patient can also come with dyspnea, as you say. Please.
Can you detect it by albuminuria? Is there endothelial dysfunction in other organs like the kidney?
No, I don't see a cluster here. Albuminuria is not a feature of patients with microvascular angina in particular. A potent risk factor for microvascular angina is diabetes. So microalbuminuria can be there because of diabetes. But we have about 50 to 60% of patients with microvascular angina who do not have relevant risk factors. In some of these patients, the mechanism is inflammation. And we know that patients with, in particular, rheumatoid arthritis or scleroderma can develop microvascular angina. And in this case, we know that the issue is really inflammation. But also in patients without chronic inflammatory diseases, in a subset of patients with the microvascular angina, we find raised levels of CRP. And then we have 10-20% of patients without risk factors and without evidence of inflammation. And the cause of microvascular angina in this subset of patients is still rather obscure.
I would like to ask a question, but I don't know if that's...
The red one. The red one. The red
The
one.
red one on the right.
On the right.
Yeah.
The case of, as you say, the lady who comes in with the angina, typical presentation of angina, normal coronary arteries. So, probably there's a small vessel disease. How do we approach the diagnosis? What do we do in order to come? Because this is not an infrequent situation. So what?
I like this. Okay, now it works. Well, I have to highlight what you say. It's a frequent situation. We overlook it, but it's frequent. Now, in this case, a very simple, non-invasive test to distinguish between angina caused by epicardial stenosis and microvascular angina is an echo stress. Because if in these patients we infuse adenosine or dipyridamole, this in the presence of epicardial stenosis cause angina, ST depression, and wall motion abnormalities. This is a typical pattern. While in patients with microvascular angina, the patient develops pain and ST depression, but in the absence of wall motion abnormalities, because microvascular dysfunction is spread throughout the myocardium and doesn't reach the critical mass which causes regional myocardial dysfunction. This is a useful test. The other test which is useful for this type of diagnosis is acetylcholine testing. Patients with angina and no obstructive atherosclerosis should undergo acetylcholine testing in the cath lab. In the last guidelines of the European Society of Cardiology, we have given this recommendation in patients in whom we suspect microvascular dysfunction, microvascular angina. Acetylcholine testing should be performed systematically.
Very last question. You mentioned microembolization as one of the potential causes of, and what do you think? It's difficult to demonstrate it apart causes of prothrombotic state like atrial fibrillation. Do you think we underscore the value of this?
Well, there's a recent study published in Circulation highlighting this issue that perhaps we may miss something of these patients. I think that this mechanism is not so frequent, is perhaps the least frequent among those which can be responsible of MINOCA. But it is very likely to be the mechanism in patients, for instance, with LV thrombus or in patients with a thrombotic mass within the heart. It's something to keep in mind. But what is even more important is when the patient comes to the cath lab with a diagnosis of infarction, typical chest pain, and troponin raised, and we do not find obstructive atherosclerosis, again, we tend to say, okay, this patient doesn't have a cardiac problem, we send this patient home, and we make a big mistake because the outcome of these patients is not so good. And in the presence of MINOCA, it is really important to make a good diagnosis. I mean, we have to establish why the patient is on the table in the cath lab with myocardial infarction. Although epicardial stenosis are not there, we must make an effort for a good diagnosis because this is the premise, as usual in medicine, for a good treatment.
It's not an easier case, it's more difficult. Yeah, okay, thank you very much. We go on.